So what do you think are the biggest components involved in unresolved pain, and what do you think needs to be changed?
Components to unresolved pain, just from a societal standpoint, from a patient perspective, we talked about before is, everyone's fixed on especially in America, everyone's focused on a diagnosis, a test, an X-ray, an MRI. They're looking for that pathoanatomical answer why their pain's there. That's we got to dispel that first. So a strong clinical using therapist who understands, the biopsychosocial model, understands pain sciences. There's so much research on pain now, and I was really influenced by Lorimer Moseley and David Butler's work. There's a lot of therapists in the U.S. now doing that kind of research as well. And really from there, as a clinician, as much as I've done a lot of different things, I still, by heart, after 20 years, I'm still feel called and still feel really rewarded being a clinical therapist, having huge empathy for patients who are in pain, and be able to tell a story or a narrative that makes sense to that patient. I think that's the key. I think there's so much research out there. There's almost so much stuff being written out there for patients to kind of, or even science and research about pain, how pain works. But I still feel like the general society and even clinicians as a whole probably can do better about trying to explain not just pain itself, like why pain hurts, but also why it's relevant to them specifically, the patient themselves. So I think there's been a lot of great stuff on pain itself, pain sciences, pain education. But I think we can improve a little more on really delivering that to make it really personal and relevant to that specific patient we're talking to, which means we really need to know who the patient is, the sports they love, the motivation factors, what really is driving their pain, things like that. I think let's really get deep down of who they are as a person to figure out why they're doing what they're doing that cause pain. Outside of traumatic injury, we get a lot of people who are runners and, they run because their dad died of a heart attack when they're younger, so they're afraid to, whatever. So they're motivating factors, what's fueling their fire, of what's driving them, not just this is what pain is. So I think really digging down to their story, which is, I'm not trying to promote my book in that regard, but the book is, really ties into like, what are you really doing in that regard? Why are you really driving yourself to do this? Because, your pain's happening for these physical reasons, but there's still a reason why you're doing this for yourself, fear avoidance models. Why are you not moving? Because you're afraid to, things like that too. So on the flip side too. So I think really, understanding the pain sciences and then really delivering a strong message and clarity to the patient, the individual patient, so they can really understand and it relates to them specifically.
Yeah, so I think it's kind of mixed with the next question I had, that like how we can help them. So I think you pretty much said like education, understand their history, the big picture, the reasons behind they do what they're doing. Anything else that you want to mention?
Once you get that story down, you can take a proper history and then, educate the patient properly. You still got to have the interventions and tools to deliver, right? So you can talk pain science, central pain processing, and all these different things. But if you don't have the tools to get them better, whether it be manipulation, dry needling, exercise therapy, wherever that person needs to get to their goals, whether it be just go for a walk, hold their child, play golf, go for a run, right? Play professional sports. If you don't understand where they're trying to get goal-wise, you guys still got to have the tools to get there. So you got to have a multitude of clinical tricks up your sleeve to be able to get there, because not one thing, would be dry needling or nerve gliding or manipulation, is going to get you there. I think most therapists know that. The more diverse portfolio you have in your clinical treatment regimens, the better. And then you got to know when to use them, when not to. You can't just get reliant on one system only. I think you got to have a big diverse bag of tricks and know your clinical talent to know when to apply them, when not to.